Okay, everyone, I think we might get started now just because we do have a jam-packed agenda today and we don't want to go overtime. So, good afternoon, everyone, and thank you all so much for joining us today in the second in our three-part webinar series from the Olive Wellness Institute. My name is Sian Armstrong. I'm a dietitian working at the Olive Wellness Institute and I will be your host for today. Now, before we begin, the Olive Wellness Institute would like to acknowledge the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respect to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today. So before I introduce you to our wonderful speakers, I do want to just quickly run through some housekeeping items. So after the presentations today, we will have some time for a Q&A with our speakers. So if you do have any questions, could you please pop them into the Q&A box and not the chat box. So make sure it's in that Q&A box. And if your question is for a specific presenter, it'd be great if you could also just add their name so I know who to direct the question to. Now, this webinar today is being recorded and we will upload it to the Olive Wellness Institute website after today, and we will email it out to all the attendees and those who couldn't attend tomorrow. So if you miss it or you have to jump off early, don't worry, we will send you out a recording. Okay, so let's talk about today's exciting topic of nutrition for women. Women's health needs vary widely between individuals and at different life stages, but one common theme is the need for good nutrition. The Mediterranean diet and extra virgin olive oil have been shown to assist with health issues ranging from general well-being through to reproductive concerns. So today we are so lucky to hear from our two expert speakers, accredited practicing dietitians Susie Burrell and Stefanie Valakas, who will take us through the nutrition challenges women face, as well as some common reproductive health concerns such as endometriosis and polycystic ovarian syndrome. So, first of all, we will be hearing from Susie Burrell. Susie is one of Australia's leading dietitians, known for her extensive background in both nutrition and psychology, and for her practical, easy-to-understand approach to diet, nutrition, and well-being. Susie has worked as a paediatric and sports dietitian for more than 20 years. She's worked at the Children's Hospital at Westmead for more than 10 years, specialising in eating behaviour and weight management, and as a sports dietitian has consulted to Sydney University Sport, the St George Illawarra Dragons and the South African Blue Bulls. Susie currently consults to a number of industry partners and sees athletes, children and adults for weight management and healthy eating at her private clinic in Sydney. Susie is currently the resident dietitian on Channel 7's Sunrise, has a weekly column in the Daily Telegraph and is regularly called upon to comment in the media on all areas of nutrition and healthy eating. Susie holds a master's degree in coaching psychology at Sydney University, loves going on long walks around Sydney and is kept pretty busy with her twin boys, Gus and Harry. Our second speaker for today is Stefanie Valakas. Stefanie is an expert fertility dietitian and nutritionist and founder of The Dietologist. Stefanie and her virtual practice are dedicated to excellence in nutrition for reproductive health concerns, fertility and pregnancy. Her passion for nutrition in this space has truly grown from her experience helping her clients online around the world and also through her own personal experience of navigating a diagnosis of endometriosis. Stefanie has been recognised for her contributions in the fertility nutrition arena as a finalist for the Dietitian of the Year Awards for 2020 to 2021. Stefanie truly believes every hopeful parent should have access to scientifically backed nutrition information to prepare their bodies prior to conception, support them through fertility treatments, pregnancy, and ultimately bringing home a healthy and happy baby. So let's kick off our first presentation. Susie, I'll ask you to please turn on your video and I will stop sharing and hand over to you so you can share your screen. Thank you, Susie. Are you there? You're just on mute as well. So if you could just unmute yourself and turn your video on, that would be fantastic. There we go.
Hi everyone. Let me just get all my screens sorted. So I can see the right thing. Does it come up with the screen share now?
Yeah, we can see your screen.
You can see it. Okay,
yeah,
I just can't see my Zoom, that's all.
That's right. If you could just put it in present mode so we can see the screen, the slides nice and big, that'd be great.
We have practiced this. Okay, is that right now?
Perfect. Thank you.
There we
Susie.
go. All right. Hi, everyone. Thanks for that. We had rehearsed this, but as usual, things don't always go to plan. First of all, I should say a very big thank you to the Olive Wellness Institute for the invitation. It's always very nice to be asked to speak, so thank you. But in particular to Sian for her patience with me on admin, which is not my strong point. And hopefully today my nutrition expertise is a lot better than the admin skills that I've shown. So let's go. So by way of background, I spend most of my clinical time working with women. My bio did say sports and athletes, which I do, but primarily I would say 90 to 95% of the clients I see are women. As I get older, I am a lot more interested in women. And I think the beautiful thing about dietetics in practice is that we really have started to specialise and are able to, like Steph, really focus on fertility. And I have really focused in my clinical work on women and weight control, which I get huge amounts of enjoyment out of and satisfaction. And so a lot of what I'm speaking about today is based on my clinical experience. Now, I have provided references for key pieces of scientific evidence, but I want to be very clear that I'm a practitioner. So I'm very much interested in practical application and my observations in practice. So you'll see from that there's a lot of sort of extrapolation from what the research shows us, but how to support women in making these dietary changes in busy life. Because if I put the question to you, how are the women in your life doing? As just having a few thoughts about it, whether it's your family, your friends, your clients that you're seeing, I don't know, my experience without preempting the discussion is they're not living a life like this. I don't know any woman who is juggling kids, family, full-time work, career, potentially fertility, without looking a lot more, a lot more like this. Life is so challenging. Just in the few minutes before this presentation today, I was talking to a client of mine who said, I've fallen off the wagon. I know I just can't get things together. And really we spent that time not speaking about what she should be doing, but the systems and structures in her life to make healthy eating easier, because my personal observation and belief is that most of us know that vegetables are good and we should eat a whole lot more of them, and we should order Uber Eats a whole lot less. But the demands and pressure of busy modern life are relentless. They haven't got any easier, if not exponentially more difficult in the past year or two. And so the last thing I need is my clients to be feeling more guilty about what they're choosing when it comes to their food. So I really am looking for practical application and strategies to make healthy eating and lifestyle easier for these very overwhelmed women. So absolutely thinking of it in life stages. Whilst the bulk of my females I would see would be aged between 30 and 60, of course, there is also the group of younger girls who perhaps are juggling in a different way. So career, partying, dating, and those. And indeed, the group that I would see there is possibly some hormonal PCOS girls who are looking at preventing weight gain as they get a little bit older. Then, of course, the 30 to 45s, the juggle, and even if people are not juggling family, there's often big demands on their career, travel, very time poor, have a lot of pressure regardless. Then I have this group of women really coming through the perimenopause group, where the kids are perhaps a bit older and they're really learning to self-care better now that they've got a bit more time. They may be going back into the workforce. They may also be dealing with a number of health consequences, things like insulin resistance, type 2 diabetes, heart disease, bowel cancer, all rearing their ugly heads in those years as they've got more time to explore it, but also be dealing with things like unexplained weight gain. And then, of course, we've also got the cohort of women who will probably live very long lives. So it's about positive aging and not necessarily losing weight, but keeping a body weight that is allowing them to live what I describe as their best lives, so they can remain active and healthy as they may live another 20, 30, 40 years. So what are the issues? If we were putting this as a brainstorm, we would say it's the juggle, it's the stress, it's really expensive. Food is expensive at the moment. I'm sure you've noticed yourself the increase in the supermarket spend. No one's got enough time, or it's how we choose to use that time. Huge amount of social media influence, and that obviously impacts our practice and the information that people are getting when it comes to diets and nutrition. I find people are just overwhelmed with the volume of information and sometimes just can't take any more on. And life is inactive because of things that are more important. So getting to work, getting the kids to school, maintaining a marriage are often much more important than getting to the gym. And I think there has to be a certain level of respect and understanding to that as well. There's ideal and then there's reality. So I thought I would describe, it's always nice in context. So I thought I would describe a client of mine that I'm seeing at the moment. Obviously the names have been changed. 42 years old, she's a corporate lawyer. So straight away, knowing that will mean huge energy demands, or time demands. Married, 2 children, does have a gym membership that rarely gets used. She has been working at home for 2 years, so juggling her kids with her husband, has both PCOS and insulin resistance that were diagnosed many years ago, and her current weight is 89 kilos, so significantly overweight. Now, she doesn't present as someone, she doesn't come to me because she feels that she's significantly obese, but she knows that her life has resulted in significant weight gain, and she's just had that creep over the past 20 years where it's gone up almost 20, 30 kilos in that time, and now she's got a serious weight issue. So I'll come back and talk about her lifestyle changes and what we've worked on in context of some of the theory behind what we're talking about today. A little bit of the data about what's happening with our women and our women's health. And indeed, if we go to any research base, there's data around, you can cherry pick whatever you want to look at. I've had a look at Jean Hales because I think they're often up to date, and they're really looking for participants in their women's health survey at the moment. So if you're keen to do a survey or share it, they're very keen to get their data from 2022 out there. But this was from 2020, so it was actually post the initial lockdown period of COVID. 31% of the women who responded, and it was a significant, almost 10,000 sample response survey. Age between 24 and 44 felt they didn't have time to self-care in terms of their health appointments. Only 40% considered themselves a healthy weight, which obviously means 60, as we would know from the data, are overweight. More than a third reported feeling anxious. Again, I don't think you're aware of that on a daily basis. And definitely the 33% reported their health was worse since COVID, whether it's less time at home, whether it's more comfort eating, less activity, all those factors we know anecdotally are indeed not helping us with the goals we have for our clients. So going back to my case example, and I think the thing I always like to really highlight is that just because people are overweight or even seriously overweight, as my client has started out, it doesn't mean they're necessarily eating a terrible diet. So I would describe her as trying really hard with her diet. So she'd been fasting, following fasting regimes off the back of mainstream media, pushing those or supporting those as a valid way to, or an evidence-based approach for weight control. So having just the typical almond milk coffee, she thinks almond milk's healthier. Then having a later start to the day after the overnight fast with oats, fruit, adding the good fats in there. Salad with protein, again, trying to reduce carbohydrate intake, having the veggies, but then the hummus, and then a black rice with salmon. Now, this is, as we know, nutritionally not a bad diet. It's relatively low in fat. The carbohydrates not overly high, the calories are relatively controlled, but it's not optimizing metabolic function. It's not fueling at the right time of day. There's extreme differentials in carbohydrate intake, and it's not supporting her in her inactive lifestyle in terms of trying to fuel at the right times and perhaps fast overnight when the muscle's less active. So indeed, this would be, and of course there's a degree of underreporting. We know that theoretically people underreport 25%, but what I want to really stress is clients I see in general are not binge eaters. They're not eating huge volumes of food, but they've become metabolically insufficient as a result of a lifestyle that's very conducive to weight gain. And so then my job becomes rehabbing that muscle to burn better in a way that that client can assimilate that regime into a very, very busy life. Oh, hang on, getting ahead of ourselves, getting excited. So as I've just described, too much carbohydrate for the amount of activity, even though it's not an overly high carbohydrate intake overall. And I also want to stress that client does have a degree of insulin resistance, but I would argue that many clients who have got 20, 30 kilos on probably do have a degree of insulin resistance, which we need to clinically take care of. Disproportionate amount of calories, the fat ratios are unbalanced, which is relative to what we're about to talk about, of course, in the context of good fats in our diet and extra virgin olive oil, grossly insufficient vegetables, reward-based eating at night, and clinically low calcium intake, which has consequences, of course, for her bone health long-term. So I pose the question because I think there's a belief out there, I don't know if it's a health professional belief or general, that it's easy to eat healthy. But I don't know if it is, because this is all the steps, if you think, that cognitively have to occur to put a healthy meal on the table if you don't have a science degree. So first of all, you've got to find time to plan that meal. Then you've got to make sure that any meal that you choose, or if you pluck a recipe out of a book, that it meets the health goals you have. So in the case of my clients, perhaps a bit lower in carbohydrate. You've got to buy all the ingredients. And then if you go to the supermarket and go to buy the ingredients, the chance that something's missing is probably quite high. Often it's not there. You think, what am I going to do now? You have to afford them. If you ever costed out the cost of an individual recipe, you know, you can be $30, $40, $50 per meal, which is often not financially viable for our clients. Then you have to know how to prep those individual ingredients. You have to actually prep them. Then you have to actually cook the meal. And then if you're feeding a family, it's unlikely all the kids are going to also like that meal. So my argument is that it's difficult unless you have a large skill set, but even more than a skill set, you've got to have a lot of time. And that's the one variable, the one resource in our life, I'm sure we would all agree we don't have anywhere near enough. So you can see that no matter how great my client's knowledge is, even if she knows all those steps she's got to take, she's got to find the time to do that. And that is a real skill in busy life. A little bit more data to go back to. This is just Australian nutritional data. You can get that off the Australian Health Institute. Australian Institute of Health and Wellness site. This goes back from dietary data. It's getting a little bit old now, but it's stuff that we know. We don't need a science paper to tell us that our clients don't eat enough vegetables, that they don't eat enough dairy, that they're overweight, and they're sedentary. I don't think I need to read another research paper that tells me that, but if anyone who's after the research, that's a link to it. And I've presented this slide many times when I've spoken because I think it just reminds us that it is a specific regime required to induce fat loss. It's not about healthy eating, and most clients I see would be eating very healthy. They're choosing wholemeal bread, they're trying to make a good choice, they're choosing plant-based milks because they think they're healthier, and it's not enough to be healthy. It's got to be calorie controlled, it's got to be balanced for macronutrients, particularly when they've got metabolic disturbance, as many of our overweight clients would do, and I'm sure Steph will refer to this in her fertility-based clients as well. It's very, very specific, and this is where dietitians have a huge role to play in directing these clients because of the nutritional specificity and knowledge that is required to achieve, to develop regimes that are conducive to fat loss in a metabolically impaired client. So that's just a very standard example of a relatively high carbohydrate, low fat diet, relatively healthy with the exception of missing veggies, compared to a higher 30-40% carbohydrate regime on a 30% protein, and the specificity that's required with prescription to achieve that into a model of eating that people like to eat. And it's also practical in a busy life, so they're not spending hours and hours food prepping. So usually I run off 4 meals a day, balanced in carbohydrate and protein with a taper at night. So they're linked with inflammation, because that's why we're ultimately here today, and really knowing and understanding and implementing good oils in the diets of busy people. So this is some up-to-date research around it. Again, there is a growing evidence base to support Mediterranean diets in reducing inflammatory markers in the body, and as a result of that, heart disease risk. So that's some of the earlier work. And then luckily we're getting a little bit more specific in more recent papers. Specifically when we're talking about the natural anti-inflammatory effect of good quality, and I'll stress good quality Australian extra virgin olive oil, it's that special phenolic compound oleocanthal, which has been clinically shown to have a very similar effect to Nurofen. So that's the very specific molecule that we know has that beneficial effect. As is the case in many research pieces, their review studies or recommendations or their biochemical analysis of what's going on in a petri dish. There's not that many RCTs, but there's a new one that I tracked down relevant to our discussion today, which is from a couple of years ago, an Italian study, just 18 overweight obese adults, but an RCT, where they did 3 months of a extra virgin olive oil enriched Mediterranean diet on 40 meals or 2 tablespoons a day used in cooking or as a dressing to show clinically significant reductions in oxidative stress and an increase in prebiotic action in the digestive tract. And their hypothesis is that there are some links then to energy balance in the body. So it's early, it's coming, it makes sense. We sort of understand how that would be the case, but we are having a growing pool of evidence to associate diets that are anti-inflammatory and specifically higher in that Mediterranean but good fat, prescriptive, good quality extra virgin olive oil has preventative effects when it comes to weight management long term. So let's just have a a reminder of why fat's a problem in Australia. And I had this discussion with Carolyn Creswell from Carmen's yesterday, just by chance. She said to me, I was listening to a podcast that you and Leanne had done. Leanne Ward and I have the Nutrition Couch podcast. If you haven't subscribed, please, we would love to have you on board. But we had reviewed nut bars, and part of our discussion was palm oil as an ingredient or vegetable oil in nut bars. And she said to me, do you not like palm oil because of the orangutans? And I said, I won't swear on here, I don't really think about the orangutans, not in theory, of course I do, but the reason I'm saying it nutritionally is I don't like the fat profile. And in Australia, we don't need any more palm oil filtering through the food supply because we already get loads of it through our biscuits, through our cakes, through anything, as you know, that references vegetable oil, most of the frozen food section in the supermarket, plus our relatively high intake of meat and dairy. So I don't want any more saturated fat going through. It's nothing to do with the orangutans. She had a laugh about, because our fatty acid ratios aren't good when it comes to inflammation. We know ideally, historically, to get that 1-to-1 omega-3 when fish is high amount in the Mediterranean diet, that's ideal when it comes to reducing inflammatory markers. It's estimated in Europe and America, they're at 16-to-1. Ours is a little bit better from estimates from Barbara Meyer's group down at Wollongong Uni, estimated to be about 8-to-1. So we're still pro-inflammatory, but the key to achieving those ideal ratios and promote an anti-inflammatory effect is to really fine-tune the food prescriptions on any plan to achieve those ratios that we're looking for to reduce inflammation. So the problem in our world is this is happening all the time, and a number of our major food suppliers, if you can guess what this product is, or this one, is that, you know, we're getting these vegetable oils filtering through and it's bumping up those saturates and drowning out our good monos and polys at a cellular level. Because this is what people eat. Banana bread, which is mass produced and made probably with palm oil. Our good old friends at Arnott's, you know, they're still using vegetable oil. Nutella, you know, increases of Nutella around the world are going gangbusters, and yet dominant ingredient, palm oil. Fried food, vegetable oil, processed oils, you know, this is what people are eating. And so sure, we can give recommendations, but until we really, you know, focus on the key contributors to these bad fats in our diet, it's going to be pretty challenging to change it at a population-based health level. Little reminder, I've put this slide in just because we have so many questions about coconut oil, and this is why we don't like it as dietitians. You don't necessarily need a science degree to pick that. It's heavily saturated. It doesn't have any of the positive benefits that we're looking for. It doesn't have the polyphenols. It doesn't have the antioxidant content. It doesn't have vitamin E. There's nothing good we can say about it. So you'll never hear me talk about it. And I would feel that if more chefs, etc., or paleo or keto experts actually understood biochemistry, they too would perhaps be not such big fans. So how do we get fat balance with the body with the clients that we're seeing? Definitely prescription extra virgin olive oil. I don't get paid by Cobram myself, but I keep up to date with the research and know that Australian extra virgin olive oil is superior because of that exceptionally high antioxidant content, and give very specific recommendations. So in general, it's the only oil I suggest clients cook with. It's indeed the only oil I cook with, and I work off a couple of serves a day. The prescriptive amounts range between 40 to 60 mil per day, but obviously there's a calorie impact of that. So I usually work off a couple, you know, as a dressing and then in cooking. Handful of mixed nuts, ideally things like walnuts and Brazil nuts to get those long chain polys up, bumping up the intake of oily fish. Now the recommendation is for 2 fish serves a week. I think we need to double it really, to really optimize omega-3 intake and get those ratios where we want it to be. We absolutely have to minimize intake of processed snack foods because of that vegetable oil filtering through. And even if it's canola, it's still not going to be the strong anti-inflammatory effect of the natural fats coming from nuts and seeds in their natural form. And absolutely a focus on reducing meals away from the home. We know that 1 in 3 meals minimum, I think it's probably more now because that is old data, is consumed away from the home, food courts, cafes, Uber Eats, and we know the oil is likely to be pretty crap. I would love to see some data on oils being used as a student project even, or a research paper in Australia, and hopefully that's something that our partners like Cobram will be looking at, collaborating with the university, because I think that data would be pretty alarming if it came through. So some practical little tips. Clients don't follow diets. They think they do. They do their version of a diet. They do their version of my diet, and they do their version of any diet that's out there, because ultimately they eat out a lot. And so most diets, as we know, are not conducive to that. Their lives in general are conducive to weight gain, as we've discussed. They're time poor, they're in sedentary lifestyles, they're under the pump financially, they sit down all the time, they need to work. So we have to look at strategies to undermine that, and adding in more and more, adding in more food prep and more exercise is not going to be achievable for most of them. Absolutely, they'll take the parts of the diet they like and not do the rest. Ideally, we want them to eat a lot less saturated processed fat and a lot more natural long-chain fat. So they need practical solutions and strategies, and they really need things that are going to be very quick to prepare, because time just is not a resource they have much of. So what do I spend my time doing? I spend a lot of time on the daily structure. So I want to know exactly how the morning pans out. How rushed are they? Do they need to prepare their breakfast the night before? Do they need to prepare their lunch the night before? Do they need to prepare all their meals on the weekend? So I spend a lot of time on that systems approach, which is actually an approach we use in coaching psychology in a corporate environment, about the corporate systems to support people and their environment. But I have extrapolated that and I use it in a nutrition context to create systems at home that are conducive to healthy eating to make it easier. And I simply work on meal balance. Have a carb, have a protein, have a good fat. So yes, at a very prescriptive level, I would be giving amounts for portion control, but I also work off some very general model to, if they're out, they can pick a protein and try and look for good fat. And it's that day-to-day systems that become the default, the habit. So this becomes the foundation. So they've got 4 or 5 days of foundation eating to allow for these sort of more social weekends and time that is no structure whatsoever. And as we know, planning and prep is the key to success. It's not knowledge. And we have to remember most of the meals, well, not most, but 30% at least are consumed away. And as such, really, we can do little amounts with our individual clients, but really it's going to be food industry and ultimately supermarket that has a major impact long-term on anti-inflammatory diets and changing those oils in the food supply to help reduce that pro-inflammatory effect. So I guess maybe I'm getting a bit older and a bit cynical, but until big companies like Arnott's change their oil, it's going to be pretty difficult to make major population health changes in these pro-inflammatory disease states, because unfortunately that's what people eat. And we would love some data on food consumption patterns. So if there's any collaborations out there with students or researchers, I'd love to see exactly what oils are in the bulk of the restaurants and have a bit more of a push to better oil quality because of the profound effect that will have on Australia's health and inflammation long term. So we whiz through that because I know Steph's got a lot of good stuff to go through, very prescriptive when it comes to fertility, which is of major interest, I know. But I'll be here for any specific questions or prescription diet questions, but I will now hand over to her.
Thanks, Susie. I'll just go and share my screen. Let's get it to full screen mode. Are we all good? Yep.
Yes, looks great. Thanks.
Perfect. Thank you. So I was going to talk about fertility, but then I know Olive Wellness Institute has done an amazing webinar on fertility and extra virgin olive oil and the Mediterranean diet on that topic already. So I thought instead, let's talk about some common reproductive health conditions that affect women, specifically PCOS and endometriosis. So those are the two I'm going to be focusing on today. So PCOS, just an overview of what I'm going to cover, what it is, the common complications, just a brief snapshot about diet and PCOS, extra virgin olive oil and PCOS and the evidence to date, and some practical strategies and overcoming barriers to using extra virgin olive oil in PCOS management. And then for endo, especially close to my heart, what is endometriosis? Again, common complications. Diet and endometriosis, just a brief snapshot again, extra virgin olive oil and endo and the evidence to date, and some tips around implementing with your clients. So let's get into it. Part 1, all about PCOS, which stands for polycystic ovary syndrome, which is really a collection of symptoms. And honestly, I actually think this is an incredibly misleading name for the condition. It is fundamentally a disorder of reproductive hormones and has little to actually do with quote unquote cysts on the ovaries, which we'll get to in a moment in terms of diagnosis. So to be diagnosed with PCOS, we do need to fulfill certain criteria. It's called the Rotterdam criteria. And the first piece can be that people with PCOS commonly experience irregular periods or rather irregular ovulation, more likely. So usually menstrual cycles can be less than 21 days, or more commonly longer than 35 days. The second criteria is biochemical evidence, so blood work that speaks to this, or physical symptoms of high androgens. So things like acne, hair loss, particularly hair loss from the head, and hair growth. Particularly, clients complain a lot about chin hair and facial hair, but sometimes they'll complain about back hair or arm hair or excess leg hair. And then finally, you've got the pelvic ultrasound to show polycystic appearing ovaries. So this is a very specific formation on the ultrasound. So they're looking for 12 or more immature follicles, which are eggs to be, in at least one ovary. So these aren't actually the typical thing of what we think about as cysts, but rather they are multiple almost ready eggs that are hanging out in the ovaries that are giving it its polycystic appearance, which sonographers use. And this often leads to a lot of confusion with clients about what this definition means. So 2 out of 3 of these criteria can be met to be given a diagnosis of PCOS, which means you may not even need the polycystic ovaries on ultrasound at all to have that diagnosis. So PCOS affects between about 8 to 21% of people with ovaries of reproductive age. So Indigenous Australians are likely to be more affected. So 21% is the statistic amongst the Indigenous population. So it's up to 1 in 5 people that are going to have PCOS. And some of the common symptoms I'm sure many of you are familiar with if you've seen clients with PCOS before are irregular and long periods, weight gain, especially centrally around the abdomen. Central adiposity is a major complaint. Up to 85% of people with PCOS will also have a BMI over 25. Insulin resistance is incredibly common, although not a diagnostic criteria of PCOS. So about 80% of those are going to have insulin resistance. Feeling tired, feeling constantly hungry, craving high carbohydrate foods, sugary foods. I recall one client once who told me she would have such intense sugar cravings, she would wake in the night and eat 22 chocolate bars. And I had to check that she wasn't giving me some hyperbole there, but it was in fact true. So these can be quite intense and at random times. Hirsutism, which is excess hair growth, like I said, hair loss or hair thinning, acne. And there's also increased risks of certain mental health concerns amongst those with PCOS, specifically depression and anxiety. And also there's an increased risk of developing an eating disorder and disordered eating patterns as well. So it's a particularly vulnerable group that we have to be mindful of. Gut symptoms as well is more likely to occur. People with PCOS are actually more likely to have IBS as well. So some of those symptoms can pop up too. So look, there's always complications when it comes with these types of health conditions that are chronic inflammatory in nature. So metabolically, we're talking about insulin resistance, increasing risk of developing type 2 diabetes. There's also an increased risk of developing gestational diabetes in pregnancy and associated complications. Many of the people I work with are trying to conceive, so this is particularly relevant. High cholesterol and cardiovascular disease risk is another one, and obstructive sleep apnea is another. Increased risk of fertility interventions being required, although once you've got good management of PCOS, generally speaking, fertility can be restored because you've got more frequent and regular ovulation. It's more predictable. It's easier to time sexual intercourse to conceive. However, some people will require some interventions, so ovulation induction, IUI, and IVF. And there's also an increased risk of endometrial cancer. So just keep in mind that if you have a client who hasn't had a menstrual bleed for over 90 days, it is important that they see their doctor to induce a menstrual bleed, because that buildup does increase the risk of endometrial cancer significantly. Like I said, increased risk of mental health concerns, including eating disorders. So diet and PCOS is going to be highly dependent on the goals and the needs of the client that's presenting to you, because no two individuals with PCOS are going to present identical. Some will have hirsutism symptoms, some will have acne, some will struggle with their mental health, others won't struggle with their weight. And so naturally, whilst these principles are great as a foundation, we're going to need to hear them out and individualize our approach to their needs and goals. So some focused areas that are generally relevant are insulin resistance management strategies. So a lot of what Susie just spoke about there with her case study is super relevant here. So shooting for low GI, whole grains, moderate carbohydrate intake, and matching that with activity levels. If weight management is a relevant and desired goal, there is research to support that a small amount of weight loss, particularly body fat reduction, can be enough to reinitiate ovulation. You don't necessarily need to be back at BMI 25 to get that result. We want to be focusing on androgen lowering strategies if there's a presence of high androgen levels. So 2 cups of spearmint tea per day can assist with hirsutism, for example. And Mediterranean dietary principles is also great. And we know this from the SMILES trial for mental health by Felice Jacka. Certainly some of those principles are going to be relevant and valuable for our PCOS clients, especially if they're struggling with their mental health. And then if they're trying to conceive, fertility nutrition principles and being mindful of their increased risk of disordered eating and eating disorders and mitigating that increased risk, because sometimes our PCOS clients can devolve into hypothalamic amenorrhea, which is a loss of period due to inadequate energy, and over-exercising because of the advice that they've been given about managing their PCOS has been a little bit too extreme, and it kind of turns into another beast in and of itself. So just being really mindful of their past eating patterns, their eating behaviors and their tendencies, and really cluing into that so we can give, of course, safe and ethical advice. So I've just picked 3 key dietary patterns and some research around them to compare them around how they help with managing PCOS. So a low GI diet naturally is a reasonable choice when we're talking about those with insulin resistance, and trials to date have shown amongst people with PCOS that there is improvement in menstrual regularity, there's improvement in weight reduction via improved satiety, so feeling fuller for longer, increased insulin sensitivity, and lowering androgens as well. So naturally, a reasonable choice for PCOS. I think it was about, although I feel like it's hanging around, but it was about 4 or 5 years ago where I cannot tell you every single person with PCOS that I met wanted to know about the keto diet or was using the ketogenic diet or wanted me to help them undergo a ketogenic diet for managing PCOS. And the studies to date about the keto diet and PCOS are actually very small. So they did one study of about 11 people and they used less than 20 grams of carbs a day. And out of those 11, only 5 were able to make it to 24 weeks of the ketogenic diet. Naturally, it's a very hard diet to maintain. Although the ones that did make it to the end were able to show some improvements in body weight, a reduction in free testosterone, improvements in fasting insulin, and improvements in the LH to FSH ratio. But I guess the question here is, you can have the perfect diet, but if it's not actually getting done, it doesn't really matter. So it's kind of piggybacking off what Susie was saying. There are so many other pressures, and maintaining such a strict and low carbohydrate intake can be incredibly challenging for the vast majority of people. Now, the last diet to consider is the Mediterranean diet. We know that this is helpful to reduce inflammation, to help improve cardiac outcomes, lipid profiles, really important for that metabolic profile for those with PCOS. And studies in PCOS populations show improvements in glycemic control, in menstrual regularity, in blood pressure, cholesterol profile, and even the shape and size of the ovary and the follicle counts and androgen levels as well. So certainly lots of positive and beneficial research about the Mediterranean diet that we know is underpinned by fruits, veggies, whole grains, extra virgin olive oil, legumes and beans, herbs and spices, and seafood in particular. So now let's think a little bit more about fat profiles with PCOS, because both PCOS and endometriosis, which I'll get to in a moment, both are underpinned by a chronic inflammatory state. with endometriosis in particular, that kind of generates pain, but with PCOS, it's more about that metabolic aspect in particular. So we want to be trying to mitigate that as much as possible through diet, and fat profile adjustment, as Susie was referring to, is key. So I just want to pick out a few key things from the literature around extra virgin olive oil for PCOS that you can point out to maybe people that you're working with who have PCOS. So obviously, a really favorable monounsaturated fat profile is going to be really helpful for lipids. We've seen that it helps to decrease LDL cholesterol in those with PCOS, and subsequently, that's going to be beneficial for long-term cardiac outcomes. Then we've got vitamin E. Vitamin E is a fat-soluble vitamin and also really uniquely behaves like an antioxidant and can be helpful for chronic inflammation. I'll talk a little bit more about that in the endo section as well. And then we have polyphenols, which are a big group of a variety of antioxidants, which all can naturally help with inflammatory status and can be helpful for insulin sensitivity as well. And interestingly, there's been a reduced incidence shown of non-alcoholic fatty liver disease in those with PCOS who consumed extra virgin olive oil as well. Naturally, I love this diagram from the Olive Wellness Institute. Extra virgin olive oil is the best choice when it comes to PCOS for its superior antioxidant content. And it is the only fat that I recommend being used. I'll talk a little bit more about implementation, overcoming barriers in a second, because sometimes we get, what about in this dish, or how can I use it in this way? And these are all valid things that we need to try and overcome with our clients. So interestingly, one of the biggest concerns that we see isn't that much extra virgin olive oil every day going to be too many calories and cause more weight gain? And interestingly, some RCTs are showing that amongst those with excess body fat, there is an enhancement in body composition and in blood pressure in those that used extra virgin olive oil compared to soybean oil in a test meal of a high-fat breakfast. Now, obviously, it's a very controlled environment, probably not very reflective of most women's lives, but the target is still that 25 to 50 ml of extra virgin olive oil per day. And obviously, you're going to have to adjust that based on other competing nutritional priorities for the client, but certainly you want to be using EVOO as exclusively as possible with your clients with PCOS. All right, shifting gear a little, and let's now talk about endometriosis. So endometriosis is a chronic inflammatory disease. It's characterized by the growth of cells that are similar to the endometrial lining growing outside the uterine cavity. They're not actually the exact same cell structure. The stage of the disease, so usually stages 1 through 4, does not actually correlate to the pain or the symptom profile, as in people with stage 1 endometriosis, which may have a small lesion or a couple of small lesions, may be in debilitating pain every day, and others who have significant distortion of their anatomy, their ovaries are in the wrong spot and ligaments are attached to the wrong place, may actually be quite asymptomatic and walking around and have no idea at all that they have endometriosis. So really important to keep that top of mind when working with people. So to be diagnosed with endometriosis, there are 2 main ways to be diagnosed: a clinical diagnosis, which is a suspected or unconfirmed way to be diagnosed, which is made with a thorough history, various investigations. Diagnosis is often made as symptoms align with that of endometriosis, and it's just so common, which we'll talk about in a moment, that it's just so likely that it is. The gold standard, however, is a laparoscopy surgery, which is keyhole surgery where cameras are inserted through the abdomen, kind of like what you're seeing here in this picture, and an expert surgeon cuts out the lesions and sends them off to pathology for them to be confirmed as endometriosis, because sometimes it's other stuff too. So 1 in 9 people that have a uterus are going to potentially develop endometriosis. There's been some whispers that the new statistic might even be as high as 1 in 7, which would not surprise me in the slightest. And there's multiple different theories as to why we're seeing such an acceleration in the rate of people having endometriosis in the population, which is a story for a different day, I think. Just to be aware of, on average, it is taking 6 to 7 years to receive a diagnosis from the initial presentation and complaint of symptoms, and most people require multiple doctor's visits and investigations. It's meant to be an and, not a 7, sorry. Common symptoms, although not exhaustive, like I said, you can be completely asymptomatic. So really important to note, you can have all of these, none of these, or one of these and still have endometriosis. So pelvic pain is the most common, including period pain, pain with ovulation, and non-cyclical pain. Often clients will complain of pulling, twinging, and other kind of stabbing kind of pains in the abdomen region. Heavy menstrual bleeding with or without the presence of clots, fatigue, pain during sexual intercourse, pain with bowels opening or urination, bladder and bowel concerns, including more frequent urination, constipation, diarrhea. Bloating is almost a universal. I would say it's very, very rare that I don't have an endometriosis client that does not complain of a bloat, but I mean, it happens. Mood changes and reduced quality of life. Pain can impact school, study, work, or relationships. And just keep in mind as well, like endometriosis is rated as one of the top 20 most painful conditions. It's up there with passing kidney stones and cluster headaches and sciatica pain. And it's one of the most frustrating things to not be validated by healthcare professionals. So just would really encourage you to put your extra compassionate hat on, because they've gone through many hoops often to get a diagnosis. Subfertility and infertility. About 30 to 50% of those with endometriosis will experience delays in trying to conceive. And there are some new studies showing that there's increased risks of early labor and small for gestational age babies amongst those who become pregnant with endometriosis. Other complications are disability due to chronic pain. There's people that are unable to work, study, or be social due to their pain and significant endometriosis, the significance that endometriosis has impacted on their lives. And naturally, that can have a consequence on mental health as well. And then, of course, we have the anatomic physical distortion of organ symptoms. If endometriosis rapidly progresses, we can lose organs, ovaries, most commonly fallopian tubes, but there's been bowel resections amongst clients. There's been kidneys being lost, appendixes been lost due to endometriosis. And then, of course, naturally, any surgical complications thereafter, colostomy bags, etc. So let's now think about diet and endometriosis, and the exact same thing as what I said about PCOS. Every person's going to be uniquely different because the symptom profile is different and their goals are going to be different. Somebody who's coming with endometriosis with debilitating pain, who isn't interested in fertility, is probably going to have a different plan to someone who is relatively asymptomatic but is aware that the inflammation that endometriosis causes is hurting the quality of their eggs. So different goals. Focus areas are really going to be on the anti-inflammatory nutrition principles. So plenty of antioxidants, think of fresh fruit and veg, herbs and spices, and of course, extra virgin olive oil. Dietary fiber, minimize those excess saturated and trans fats wherever possible. They're strongly associated with increased endometriosis risk and worsening of symptoms. Same with alcohol intake. Red meat intake, high levels should be reduced, but you don't necessarily need to go completely red meat free unless it's the desire of the client. Gastrointestinal symptoms, you have to address them. If they're a complaint, 2.5 times more likely to have IBS amongst those with endo. A low FODMAP diet can be helpful in navigating the GIT concerns, and sometimes that translates to a benefit in endo-related pain, so just keep that in mind. Navigate any food intolerances and or food triggers. Much more likely to have a food intolerance or a food-related trigger amongst those with endo, so keep a great food and symptom diary with them. It can be really valuable. Correct nutrient deficiencies, iron, B12 and vitamin D are all ones that are likely to go out the window with endometriosis, especially with big menstrual losses, and fertility nutrition principles where relevant. So again, just comparing a few key diets and their research to date. I've included all the references at the end for you to visit. So omega-3s, antioxidants and dietary fiber from fruits and vegetables are associated with anti-inflammatory effects specific to endo. And interestingly, whole grains can have a protective effect too. And this is one of the main groups that I find people with endometriosis avoid. They feel confused. Should you go gluten-free? What about wheat? What about, bread, etc.? And it tends to be one that they avoid. Anti-inflammatory nutrition before and during pregnancy with endo can actually help mitigate some of that risk of preterm birth. So important things to maintain before and during pregnancy as well. These are lifelong nutrition strategies that need to be learnt. A low FODMAP diet, there's some amazing evidence for low FODMAP diet for those who have both endo and IBS. Excuse me. 72% of those with endometriosis who had IBS who followed a low FODMAP diet experienced a 50% plus improvement in bowel symptoms within 4 weeks. And progression through challenge phases, I must say, is critical. A lot of people read this study and went on pretty much a self-imposed lifelong low FODMAP diet, which we know is not good for the gut microbiome in the long term. It's certainly not good when it comes to trying to liberalize the diet and avoid excess dietary restriction. So make sure you're helping your client work through those challenge phases so they get to liberalization. And then, of course, the Mediterranean diet, the Old Faithful. Interestingly, there's actually been very little studies done to date about the Mediterranean diet and endometriosis. There's some preliminary research which still hasn't been published since 2011, which showed that there's been a reduction in period pain, reduction in pain with intercourse and pain with bowel motions. But naturally, it's a sensible choice because of the low red meat intake, great fat profile for inflammation. We know it's great for inflammation as well. And we know as well the mainstay fat extra virgin olive oil is the gold standard choice for those with endo. And here's why. So the particular things that I wanted to point out is the vitamin E. So both vitamin E and vitamin C, which both work as antioxidants, actually have been studied in supplemental form to help with chronic inflammation and pelvic pain with endometriosis. So it's definitely one you want to be aware of, and there's additional benefits fertility-wise as well. Extra virgin olive oil as well enhances the absorption of other antioxidants when we cook. So a lot of antioxidants are fat soluble as well. So we want to make sure that we've got a good base there to help maximize our fruit and veg intake as well, particularly important for those trying to shoot for an anti-inflammatory style diet. Monounsaturated fats, we know if we're getting more monos and polys, the long chains, we're going to help lower inflammation. The polyphenols naturally going to help with inflammatory status. And then again, the oleocanthal is a real good one to pick out and highlight to people with endometriosis because of that relationship to having ibuprofen. Yes, it's not the same as taking a Nurofen, obviously, when you have endometriosis, but it's almost like a small amount every day can make a big difference when it comes to pain over time. And I would love, love, love to see some really more research into the role of oleocanthal on chronic pelvic pain. I think it would be absolutely fascinating. So some tips to implement. Provide some personalized suggestions to incorporate extra virgin olive oil. So some ideas might include cooking with extra virgin olive oil, dressing salads, roasting veggies, using extra virgin olive oil in desserts, selecting the lightly flavored option. Oftentimes a lot of clients are using coconut oil or butter to bake with, so if they're a keen baker, definitely try to encourage them to swap that out where possible. And as well, culturally appropriate substitutions, so using light flavored extra virgin olive oil for Asian, Indian and Sri Lankan cuisines and recipes. Often they're using a high saturated fat option instead, like ghee. So we want to make sure that that is, if that's a frequent cuisine in their repertoire, then you want to be making sure that we're trying to optimize that where practical, and use more robust flavored extra virgin olive oil to enhance the flavor profile of more Mediterranean style dishes like Italian, Greek or Spanish recipes. So I think that is all. If you'd like to connect with me, I've got 2 Instagram accounts because I'm a sucker for punishment. So it's the_dietologist and endo.dietitian, and you can come tune into our podcast, Fertility Friendly Food, as well. I will send these slides to Sian to circulate with all the references. But yes, if you have any questions, would be happy to answer them. I might just stop sharing.
Fantastic. Thank you so much. Let me just change this view. And Susie, if you want to, there you go, you're back. Fantastic. All right. Thank you, Stefanie and Susie. They were both such wonderful presentations, and I love the really practical aspect of them as well. Now, we do still have a little bit of time for questions. We've got quite a few questions that have come through, so I might try and we might go a little bit longer. So if you have to jump off at 1 o'clock, that's also fine. The webinar is being recorded, so we might go a little bit after 1. And if you want to pop back on and listen to the recording later to catch the rest of the questions, you can certainly do that as well. But I might kick off. Let me have a look at some of the questions that we've got here. One that we would start with, we have got a question for Susie. What would you recommend for a client who has a seafood allergy and cannot have the suggested 3 to 4 serves a week? Do you have any?
Well, I think I would just work off the plant sources. So really, my favourite foods in that space are pumpkin seeds, pepitas. I love those munch pumpkin seed snacks because they've got about 8 grams of long-chain polys, which is a huge amount in a single food. The Carmen seeded crackers, very high. I think we calculated yesterday they've got about 4 grams of long chain fats from linseed. So yeah, a couple of serves of those fats as a substitute. Obviously, you're not going to recommend seafood for someone with a seafood allergy. So I just lean on those plant sources a little bit more. You know, I'm just thinking gram-wise, what I'd aim for, at least 10 grams, possibly up to 15, 20, if I was calculating. That's just off the top of my head, so it's very rough.
Fantastic. We've also had a question on the difference in extra virgin olive oil to light olive oil. There wasn't any specific person, so if either of you two can answer, otherwise I can also help answer that. But Steph, maybe you can answer that one.
Yeah, so it's really about the flavor profile of the olive oil, not so much the fat content. Like light is often used for milk or, you know, cheese, for example. It's not about the fat content. The fat content's usually the same. It's about the type of olive that is used to make the extra virgin olive oil that has a more, I guess, lighter flavor. It's not as that strong, pungent extra virgin olive oil flavor. Personally, I use the strong flavored one in everything because I'm immune to it, but a lot of people are like, oh, my stir fry tastes different because I use extra virgin olive oil. So using the light flavored can be helpful if that's like a barrier for them to be using extra virgin olive oil.
Fantastic. And I've got one more question here about olive oil, and then we'll go to some of the other general ones. We've got one about olive oil using high heat. So yeah, some patients, I think what's being asked is that some patients have concerns that you can't use extra virgin olive oil in high heat and that it can wreck non-stick pans. So I don't know, Stefanie, if you've got an answer for that one as well. I just kind of sit down and debunk the high heat concerns with the client. So I always go back to that research. You know, smoke point is not a good indicator of the oil's stability or health of the oil, so to speak. In domestic settings, extra virgin olive oil actually outperforms all other oils. And that's because of the antioxidants that within the olive actually protects the oil from forming polar compounds, which is the thing that we actually want to be on the lookout for when it comes to oil stability and quality during cooking. So yes, you should be encouraging your clients to be using extra virgin olive oil in any domestic cooking setting. In terms of non-stick pans, because I work in fertility, I do a lot of work on endocrine disrupting chemicals. So I actually get most of my clients to get rid of most of their non-stick pans and use other materials instead to reduce their intake of endocrine disrupting chemicals for their hormones. So I would recommend that you get them to switch pans, but it looks like somebody has posted some helpful links about cooking in olive oil and ruining your pan. So I might leave it to the kitchen gurus on that front. Thank you. Yes, Sarah's posted some links that we have from the Olive Wellness Institute, which answer a lot of these questions about the pans and cooking, which we know are myths. Now I've got one for Susie, a question regarding whole grains. What do you recommend to clients, especially around bread and pasta?
So bread, I think we're so lucky in Australia. We've got such a large range of dense grain breads that differ dramatically in carbohydrate load. So there's some with, 5 grams of carbohydrate right through to 60s. So I think that I just use different ones. So for example, off the top of my head, the Helga's lower carb has got roughly 20 grams of carb per 2 slices in a dense grain loaf. And I sometimes will also use the lower carbohydrate loaves like the macro one from Woolies. So I just use different prescriptive ones based on carbohydrate load and the goals I have with the macronutrient balance. So yeah, I have no issue with whole grain breads. Pasta, I'm not anti-pasta by any means, but the general recommendation I have to my clients is that I want you to consume your pasta in an amazing form. So if you're going to an amazing Italian restaurant where you're having beautiful seafood pasta, or you're having a special meal and you're savoring it and you're having seafood, I don't tend to use more refined grains, whether it's rice or pasta, as part of my day-to-day prescription. No, because I'm working with women in weight loss and I'm trying to lower the carbohydrate load at night. And keep in mind that 80% of my clients are insulin resistant. So the carbohydrate prescription I'm giving is lighter. So I'm not saying that's an ideal prescription for everyone's clients. I'm saying for mine, I do tend to say I want you to have sort of a heavier carbohydrate meal once or twice a week. And if you choose to have pasta, I want it to be amazing quality pasta rather than just loading the plate up for the sake of it. So definitely as part of my prescription, I'm giving much more focus on vegetable-based carbohydrate in the weekdays, as opposed to heavier ones that I'll recommend being consumed less frequently in an indulgent or a beautiful way, if they're going to Italian, etc. Unless they're Italian, and that's different again.
Great, thank you. Okay, we've got the next question for you, Stefanie.
Yep.
Women with PCOS who have high levels of estrogen, hence irregular periods, should soy products such as tofu and soy milk be limited? And what's the evidence around that?
Yeah, I think this is anyone who works in any kind of hormone space, and soy, there is always just constant questions about, should we be recommending soy? Should we not be recommending soy? And that's because of the natural phytoestrogens that come from soy foods. But actually, interestingly, no, we don't think people with PCOS nor endometriosis should be avoiding soy, unless, of course, it's a preference, intolerance, allergy, etc. But the reason being is the natural phytoestrogens, if we have unopposed excess estrogen, in cases such as endometriosis, very commonly, sometimes in PCOS as well, you want to be trying to compete and bring that down. And the phytoestrogens actually act as like a bit of a natural competitor. If in a state of high estrogen, they can actually weakly bind our receptors instead of the biological estrogen, and that can actually be helpful for high estrogen states. We've seen that in reverse in menopause. When we have a low estrogen state, we use the phytoestrogens there to help mitigate the symptoms of hot flushes, for example. So you can see it actually has a bit of a buffering effect either way. Would I recommend people go out and drink, copious liters of soy milk and tofu breakfast, lunch and dinner? No. But especially if they're vegetarian or they're vegan, it's going to be a really important protein source, and I wouldn't recommend avoiding it like a saturated or trans fat. I would recommend avoiding, for example.
Great. Okay, so we've got a couple of questions around, apps and programs. So they're for both of you. So for Susie, someone's asked if you have a dietary analytical program that you put your patients' diets into to assess their macros. So I'll let you answer that one first, and then there's another one for you, Stefanie, around apps.
I don't do it now, but when I was a lot younger, I would have spent many, many hundreds of hours on FoodWorks. So that was, going back how we would model lower carbohydrate or fat balance regime. So now I know that off the top of my head, but only because I've done it for a really long time. So nothing flash, FoodWorks is what I would have used. I don't, aggressively encourage my clients to calorie count or macro count, but if they are interested in what they're having, I will just use MyFitnessPal because it's free and you can get a macro profile. But I would say 1 in 10 of my clients are interested or want to do that or have the time or capacity. But yeah, no, FoodWorks back in the day, long time ago.
Right, and then in a similar vein, Stefanie, do you recommend an app for a food and symptom diary? And as well, have you seen any evidence of the Nerva IBS providing that improvement in endometriosis?
Yeah, so with the food and symptom diary app, I haven't found one that I like universally love for my endo clients. There's a couple out there, but they're hard because I work virtually. They're hard for them to share. So I actually really like the Monash FODMAP app just for the food diary section, because they've got the Bristol stool chart built in. They've got other lifestyle factors like stress, for example, that they can add in, and any other complaints that they have around abdominal pain and gas and bloating that they can add in, as well as their food. And then they can just send it straight to the dietitian via email. So that's really helpful as well for your own record keeping on top. So that's probably my favorite one. Otherwise, I have my own like templates that I use, like hard copy old school ones, because I haven't found one that I absolutely love all around. So I've made my own. And Nerva IBS certainly has some good evidence in the gut-directed hypnotherapy space for IBS. Applicability to endometriosis is just going to be dependent on how much of their symptom profile is gastrointestinal in nature, but I haven't seen any evidence yet, but I could just be behind on my reading at the moment about Nerva and endo at the moment, but it would be cool to take a look at those types of strategies. But we're seeing more and more people with endometriosis using things like meditation and mindfulness, rest, etc., to help them with their symptoms. So I think naturally that would probably show some kind of benefit.
Great. Now, in the interest of time, I think we'll probably have to leave it there. We do have a couple of other questions, but I might just quickly, before we wrap up, ask Stefanie and Susie if you have any final key messages, one key message that you'd like everyone to leave with. So I'll start with you, Susie, if you've just got anything final. Sorry to put you on the spot here. If you don't have anything, that's fine.
I think given, we're here for the Olive Wellness Institute, I think it's just really important we continue to send that very strong message around Australia and Australian olive oils, and in particular the ones we know have an evidence base. I still am shocked how many people's houses I go into, whether it's friends or even clients, who are buying imported oils. And I'm not quite sure why, because whether it's just familiar brands or they're not aware that they're often blends and not giving those health benefits. So I think, we're in a really strong position to really be continuing to preach how important it is that we are supporting Australian industry, but also Australian extra virgin olive oil because of the profoundly high antioxidant content, which is protective when it's cooked, which is giving us these health benefits. Because, I'm constantly shocked that I go and so much imported oil is still in the cupboards of our friends and family. So if that's happening widespread. So any opportunity to share that in the media or with your clients or on social media, I think is a message that still needs to get out there.
Yeah, I totally agree. I think extra virgin olive oil for universal health needs to be the mainstay fat, but particularly for those clients that you're working with who have a reproductive health condition, like pointing out those particular benefits around vitamin E and oleocanthal and all this stuff, because sometimes it's that little bit of the why as much as it is the how and helping them implement. But to stay on it, to help, to see a benefit over a long period of time, these are all chronic conditions. We're going to need to chronically use extra virgin olive oil to experience a benefit to a chronic disease. So really, I would just strongly recommend pointing out those things maybe that you've learned today, hopefully that you've learned today from Susie and I, to your clients, so that can really bring that strong message back and help them on that practical level about how are they now actually going to be using that in their day-to-day.
Fantastic. Thank you. Thank you so much for both great messages to end on. And that does bring us to the end of our webinar for today. So on behalf of the Olive Wellness Institute, I'd like to say thank you again for joining us, and thank you to our wonderful expert guest speakers. We hope that everyone has enjoyed themselves and learned something new. And if you haven't already, don't forget to check out the Olive Wellness website. I think you'll be directed there at the end of this webinar. We have a huge amount of information on all things olive products. You can also follow us on social media, on Instagram and Facebook. We put up a lot of fantastic information on there. And we do have one final webinar in this 3-part series next month, which will be focusing on the journey of the extra virgin olive oil from tree to table. So it'll take you through the sensory characteristics as well as the various uses of extra virgin olive oil from a culinary nutrition lens. So watch out for a registration link to that in the post-event email that you will receive tomorrow. We also do have a really quick survey that we'd be so grateful if you could please complete after the webinar. It's just 6 questions, and it does really help us to make sure that we're creating events that are really relevant and useful to you. So thank you again, everyone, and I hope you have a wonderful day. And thank you again to our wonderful speakers, Stefanie and Susie.
Thanks for
Thank
having
you
us.
for having us.
Thank you.
Bye.
Bye, everyone.
Bye.
Bye.